All right, this is our shoulder disorders presentation. I'm Dr. Leslie Barnes, and I will be presenting shoulder arthritis and treatment for that, rotator cuff tears and associated diagnosis and treatment for that, and rotator cuff tear arthropathy as well. The most important thing, of course, is to know your anatomy, and that includes all the nerves and vessels around the shoulder, the front and the back of the shoulder. Highlighting here, the brachial plexus and the axillary nerve. Here the conjoint tendon has been removed, and we're looking at the subscapularis tendon, the supraspinatus, and how it attaches to the greater tuberosity versus the subscap, which attaches to the lesser tuberosity, and they are divided by the biceps tendon in the bicipital groove, as you can see here. And also important to note that the conjoint tendon, which attaches to the coracoid process, is an important surface landmark, and we call it basically the lighthouse of the shoulder because it helps to orient you and guide you relative to the other anatomical structures that you're looking for, such as the tendons and vessels. Moving on to our first topic, shoulder arthritis. We always start with a history and thorough physical examination. On history or talking to the patients, you will find that they usually report insidious onset, meaning that it's happened slow and over time. There's typically not acute trauma associated, but they may have some low energy trauma that has exacerbated their condition. They typically report pain and crepitus, which is crunching or grinding of the shoulder upon shoulder motion, and of course limited motion as a result of the crepitus. And the best way to sometimes describe crepitus to patients is that it's sort of like driving on a flat tire where the axle of the wheel is bent, and you're not really gliding or rolling down the street the way you typically would, but you're rather bumping and grinding your way along an uneven surface. And that's kind of the best way to describe what shoulder arthritis feels like, because as the cartilage wears away, it doesn't typically wear away in a smooth, even pattern. It becomes disfigured, and the normally congruent ball and socket joint, which glides smoothly, then becomes disfigured by the arthritis, and those secondary changes cause pain and limited motion. Radiographic findings include joint space narrowing, osteophytes or reactive bone formation, which you can see here on the inferior portion of the humerus is an osteophyte which has formed in response to abnormal contact stresses. Subchondral cysts you can see here on both the glenoid side and the humeral head side, and subchondral sclerosis, which is a paradoxical hardening of the bone right here along the edges. That's represented by a relative increase in calcium density on the x-ray, or a white line on the x-ray. And then just below that are those previously mentioned cysts, which are pockets of air and dead bone, basically. In terms of specific radiographic views to get, you're looking for the true AP of the shoulder, which is where the anterior and posterior rims of the glenoid are superimposed, and that typically requires about a 30 or 40 degree tilt to the beam, and you can either tilt the patient or tilt the beam, but that's the best way to align yourself with the typical version of the glenoid and get the best x-rays. In addition to the true AP, you're going to want to get an axillary x-ray, which shoots the beam in an orthogonal fashion to the AP up through the axilla. In terms of non-operative treatment options for patients, they include anti-inflammatory medication, activity modification or resting the shoulder generally, a cortisone injection, which is anti-inflammatory in nature. And for arthritis, that would typically go inside the actual glenohumeral joint, as opposed to in the rotator cuff or subacromial bursa. And other than those three main tools, you can either leave it alone or go forward with surgery if the symptoms are bad enough and the patient wants to go forward. In terms of surgical treatment options, we're looking at total shoulder replacement, which in medical jargon is total shoulder arthroplasty, or reconstruction of the joint. What happens is that you cut out all the arthritis, you replace the socket with a plastic socket component that you can see here. This particular one is a polyethylene socket with 3 pegs holding the implant into the glenoid vault, and those are typically cemented in. And then on the humeral side, you can see that the humerus arm bone is removed at the surgical neck, and the arthritis is all removed and resurfaced by this metal cap, which has a corresponding post that goes into the hollow part of the arm bone, and that can be either cemented in, as is most traditional, or it can be uncemented using newer trabecular metal prosthetics. There are even some designs currently under research that have a very short stem or no stem at all. But the typical implant design that has been around the longest, with the longest track record, is the one that you see here, which is a cemented stem. In terms of our anatomical exposure, we're looking at the anterior part of the shoulder, and you're looking for a standard deltopectoral approach. And again, this goes back to our important relevant anatomy as outlined in the beginning. But you're going to find the coracoid as a surface landmark, and you're going to make your incision basically just lateral to the coracoid, or sometimes right over it, either in a vertical fashion for a limited approach or in the slightly diagonal incision that you see here, which is an extended deltopectoral approach, and that actually allows for extension down the entire arm if needed. Once you incise the skin, you'll come to the deltopectoral fascia, and that interval will be demarcated by the cephalic vein, which is identified here in the cartoon. Once you have freed adhesions from the cephalic vein, you can then mobilize the vein medially or laterally, as long as you take care to preserve the vein as best as possible and ligate any feeding branches to the deltoid when you're mobilizing the vessel. Once the vessel is mobilized, you can then find the biceps tendon, which we reported was essentially in the center of the arm bone, in the bicipital groove. And once that's incised, you will then see the subscapularis tendon the best. In order to gain access to the shoulder joint, you will need to cut the subscapularis tendon, either through a sharp incision, like a tenotomy that's shown here, using a knife blade, or sometimes you will even take the subscapularis tendon off the shoulder using an osteotome to elevate a small piece of bone, the lesser tuberosity, where the subscapularis tendon attaches. And instead of cutting the tendon off the bone, you'll actually split the bone and take that off the front of the shoulder. And that'll give you access to the shoulder joint in order to perform the operation. And again, here you can see a completed total shoulder replacement. You have here a radiolucent marker, which shows you the orientation of the cemented polyethylene liner, and that is the only radio-opaque portion of the liner for the socket, but you can faintly see here the outlines of the other pegs, and then the new joint surface. Over here on the humeral side, you'll see that the humeral head is nicely centered within the glenoid, and in terms of this circle, that'll give us the center of rotation, which we want to be approximately as anatomic as possible, and that will help you determine whether the shoulder is the appropriate size for the patient's anatomy.